Yeah, Assalamualaikum and a very good morning to all who's attending this morning breakfast at FOM. I'm Dr. Faissal, will be moderating the first sessions for the orthopedic surgery. We have our first speaker, Dr. Khairul Anwar Ayob. He's our experts in arthroplasty surgery. So he'll be sharing with us the experience in using 3D technology in orthopedic surgery. Since the inventions of 3D in a lot of other disciplines, we in orthopedic surgery also have been doing using the 3D technologies in our surgery, especially in the hips and the arthroplasty. So I would like to invite Dr. Khairul to present his talk.
Okay, thank you, Dr. Faissal. Let me just share my screen. All right. Okay, so yeah, I'll be talking about 3D technology in orthopedics. I'm Khairul Anwar. Thank you, Dr. Faissal. So this is the outline of my talk. So I'll first introduce, imaging in terms of orthopedics and the different tiers of 3D technology. And then I'll discuss a bit about the objectives of our surgery and do a bit of literature review. I'll present some cases from our series and then a short spiel about what the future holds for 3D technology. So the point of imaging in the orthopedics, the first is we need to visualize. So we've got radiographs, as you can see here, which gives us a 2D idea of the deformities and the of patients. But 2D representation sometimes can be a bit misleading. So they've updated this to CT scans, which still is 2D cuts, but you can sort of render it to 3D, as you can see here, and gives us a bit clearer idea of what the deformities patients come with and how to tackle them. So once we have an idea, they've also created this software where we can do 3D templating. We use Mimics by Materialize. So you can see here we've created a cup and tried to put into the patient's bone. And over this side is a knee replacement where we can do the sizing. And over the bottom, we actually can plan the cuts according to the arthroplasty principles, which I will discuss later. And one step further is we can print the patient's bone. As you can see here, this is during the surgery, we printed the patient's bone. So we can see and we can also feel where we are exactly during the surgery, and that will help us doing our cuts and implant placement. Also, we can print the bone and we can print jigs where we can reference our target. So this is a patient, as you can see the orange here, they have avascular necrosis of the femoral head, and our surgery plans to decompress this because there's a lot of pressure here and the bone is dead. So we can print that and it can guide us during the surgery. Also discuss this case in our case series later. One step above that is that we can individualize and we can guide our surgery. So this is a pinning guide. This is not from us, it's from an implant company. So they use the contours of the bone and help us put pins. So this pin will guide us on where to do the bone cuts. But you have to take this off, leave the pins in and put in the jigs. One step above that is a patient-specific jig. So you can see there's a slot here where we can straight away do the cuts. So you don't, you still need to pin, but you don't need to repeat steps. You just put this in and you can straight away do the cuts. The 3D printing also can help us correct deformities from the outside. So this is a paper from China where they showed that there's a displacement in the fracture. So they 3D printed these frames which can slowly reduce the fracture over time. And patients with scoliosis, now they have started to 3D print the braces, which patient can change every week or so. and that will help with the non-operative treatment of scoliosis. Of course, one step above that is we can 3D print implants. So this is a case by Prof. Azhar, which was done about 4 years ago. There's loosening of the cup. So we did a CT scan and we segmented the different implants so we know what was the problem. And basically we printed one implant which actually was put into the patient, specific to the patient's deformity. Of course, people are doing research about bioprinting, and there has been people are able to print meniscus and ears, and probably in the future, people can start printing hearts and lungs. So yeah, that's the hope. All right. So in terms of arthroplasty, the objective for surgery is to provide patients with a painless, stable, functional joint, which preferably lasts the patient their whole lifetime. This is what we tell patients. We just want to do one surgery. So in order to do one surgery, we need to follow a few set of principles, which is what we tell the MO. So this too is easier to visualize. We need to keep the limb straight because we want to equalize the loads and we want to balance the soft tissues. So this is one of our patients pre-operatively. You can see there's quite a bad varus deformity, and this is his X-ray. As you can see, the load is focused a lot more over the medial joint space. And when we do the surgery, we aim to straighten that and equalize the loads between the medial and lateral side. So if you don't do it correctly, you can see on the left side, this is 180 degrees, whereas the one in the middle, it's less than 180 degrees. So when there's less than 180 degrees, you can imagine that the load is concentrated more over the medial side. And basically this patient's knee only lasted him 3 years. So we had to do a revision surgery quite soon after the first surgery. So yeah, that's not ideal. And also you want to balance the soft tissues. So this is the knee in extension and flexion. So you can see there's 2 ligaments there. So when we do the cuts, we want to keep the space rectangular. This is what we usually tell the MOs. Why? Because we want the implants to fill up the gaps left by our bone cuts. So yeah, we need to be quite precise within 3 degrees. So if we're not precise and we do the cuts wrong, as you can see here, the implants cannot compensate for that. So unfortunately, this patient, we did it wrong, and the MCL is basically lax, and yeah, patients are not happy, and the implants won't last very, very, very long. Okay, so a bit of a literature review. So this is the aims of our the 3D printing. So is it accurate and efficient? So this is a literature systematic review in 2015. So basically, the 2 large studies is one here, basically done by American surgeon, sorry. So you can see that with the custom implants, it's more accurate by about 2 degrees. And also there is a less amount of outliers. So less amount of outliers, if you can see the hip and knee angle, it falls away from the center of the tibia. And this is another big study, 724 patients, also by Americans. So again, patient-specific is more accurate, and there is less amount of outliers, more than 3 degrees. But still, it's not by much. Still, the accuracy is better, but still, manual is still good enough. Does it improve efficiency? So this is a study by Thai surgeons. So patient-specific guides do reduce surgery time, but only by about 6 minutes. That's about 10%, which I guess is quite good. But as you can see, the maximum time saving is only about 12 minutes. What the issue that they noted from the systemic review is that there's still a lot of changes compared to what we planned. So there is still a discrepancy in sizes. We still change the cuts a bit, yeah, so it's not perfect, but it does help a bit, I guess. What's more important is what this paper discusses, in which there is a deformity around the femur. So we can't use the conventional instrumentations. So as you can see here, what they discuss is there's a lot of deformity because of fractures, mainly because of fractures. And based on this, our conventional instrumentation probably does not work, and they use the PSI. And as you can see, the results, it's quite close to 180 degrees. Next is for the hip. So for the hip, what we've been doing for the past 20, 30 years is we've been templating x-rays. So if you template this x-ray, you can see that we plan the cup to put size 52. But when we 3D printed the bone, we realized that a 44 cup is good enough, and you actually get quite good fixation, whereas opposed to a 52 cup where we actually breach the bone, and yeah, this is not ideal for the longevity or for the patient. So yeah, so it's slightly more accurate, it's slightly more efficient, and it's better than 2D templating. What about the outcome? So when we discuss outcomes in joint replacement, mainly we go to our registries. So the Australian registry is one of the largest and longest joint registries. So if you use image-derived instrumentation, the outcome is basically the same compared to when you don't use image-derived instrumentation. However, the numbers are quite different. So yeah, we might see people using this more. When we interviewed the patient, basically what we found is that the patient has slightly better, statistically significant, but probably not clinically significant improvement in their knee score function or their VAS. So the knee score function improves for about 5 points. This is 5 out of 100. And VAS improved about 0.5 out of 100, which is probably not that much. But what we noted is that there is a significantly less amount of outliers in patients who use this patient-specific instrumentation, and patients who are outliers have a significantly less better outcome in terms of their joint function scores. Okay, what about complications? So in terms of our conventional instruments, so if you remember this, we need to make a 90-degree cut for the femur. So this 90-degree cuts requires us to put in something inside the femoral canal. So we need to drill, and we need to put something inside the femoral canal to help us guide the jig, which helps us do the cuts. So when we do the surgery, basically there is a hole around the femur, and we know that patients can bleed from the bone, and yeah, this we can either cover it using cement or patient's own bone, but we know that patients still do bleed even post-operatively. And when they studied this, they noted that patients with patient-specific instrumentation, there is about 40 mils less bleeding. But the good thing is that less patients require instrumentation. This is also true in the hip, where in the hip, when they use a surgical guide, it reduces the incidence of outliers, and also it reduces the operating time, which also means a reduced amount of bleeding. So when we get outliers in hips, one of the complications is patient gets dislocation. So yeah, so this was shown in the in these two studies where one patient actually suffered a post-operative dislocation from a standard instrumentation. Okay, so that's basically the literature review. I think we can start discussing our series. So this is a patient who is, I think, about 35 years old. She had an accident about 10 years ago, and she was referred to us with this. So as you can see on the top of the femoral head, there is an area of sclerosis, and inside there's a lucency, which means that probably there is some sort of AVN happening. So we confirmed this on CT, and also we 3D rendered the CT, and we planned on how we plan to perform the core decompression. So you can take off the thing, and this is where the drill is supposed to go. So this is what we printed. This jig was actually put inside the patient, and it basically guide where we did the core decompression. So she was just done maybe about 4 months ago. I think, yeah, she's doing pretty well. This is the next patient. He's a young patient, 22 years old, but very, very obese. And he hasn't been walking for the past 1 year before he came and see us, because he had a fractured neck of femur, and screw fixation was done, but it had failed, and he had non-union and also collapse of the fracture. So you can see there's a different density of bone right compared to the left. It just shows that patient has not been walking. And we basically, this is the femur x-ray. And when he came from Penang. He came with a CT scan, which only has axial views. So axial views is still a bit confusing to us. So we managed to 3D render this. And yeah, so this is the CT scan from our software, which showed that there's a clear non-union of the femoral neck. And then we did the planning. So this is the bone. We segmented into 2 different parts. And this is the bone after the bulgus producing osteotomy. So we printed the jig. The jig helped us to identify where we want to cut the bone. And we did a valgus producing osteotomy. And this is the result post-op. And it's been 1 year, I think, since the surgery, and patient is basically the fracture is united. So waiting to remove the implant. Patient is, well, he's walking with a slight limp, but otherwise he has lost weight, which is good news for us. This is the next patient. As you can see, the left side, something has been done. Because he has deformity on both sides. So the left side, the load actually is equal on both the medial and lateral side, whereas the medial side, the loads is more concentrated over the medial side. So we did a CT scan, and the rate is where we want the ankle to be, basically. So this is where we do the cuts, and we stabilize it with the implant. So this is the results. And if you draw a line from the hip down to the ankle, you can the line basically goes through the center of the tibia. So yeah, patient is quite happy. This is another patient. He's older a bit by about, I think he's about 50 years old. But in this case, the arthritis is quite bad, involving both the medial and lateral compartments. So yeah, osteotomy probably will help with the with the alignment, but it won't help with the pain. So we decided to do 1 surgery, and we just decided to replace the knee. So how to do the cuts? This is what we did with the plan, and basically we plan to cut straight to the line of the hip knee angle, and this is where we plan to put the implants. And yeah, this is basically the results. Last patient, fairly young, I think 40 plus. She's had hip problems for the past 10 years plus, and you can see that the hip is basically, well, it's dysplastic, it's not in the true cup. If we do a 2D templating, this is where we think we should pull the cup, and we think we can put quite a big cup. But when you 3D render it, you realize that we remove the femur, the cup, when we put it there, it's a bit too high and a bit too lateral, so we won't get good fixation. So the cup is supposed to be smaller and lower, which is one of the principles of treating hip dysplasia. So this is where the cup is supposed to be, and based on that, this is the result. We did both sides of the patient. All right, so the experience, we've done probably close to about 50 patients, and most of them is complex cases. It's helpful to anticipate problems in complex cases. It's probably not useful yet for the conventional primary joint replacements. And the challenges that we face is, one is the lead times, because, well, planning takes a lot longer, almost, I think, about 3 times longer when you do it in 3D. And you need to give some time to print out the bone models and the jig. This generally takes about 48 hours. So for elective surgery, it's quite good. But yeah, for emergency, sometimes it's a bit too long. Yeah, planning, as I mentioned. So far, I have to admit, I'm probably not the best at using the Mimic software. We have Sufyan, who works under Prof. Hazar. They both are better than me. Even then, the planning still takes quite a while. And yeah, we basically need more manpower. And I think with more manpower, we can reduce this quite significantly. So there's also other uses. I was talking mainly about hip and knee surgery. For oncology also, they've been doing this. So this is a presentation by orthopedic oncology surgeon in Israel. So basically, they can 3D render MRIs, and they outline this bone with osteosarcoma, and they plan the cuts when they when they do the excision of the tumor. Also works for upper limbs, especially in trauma. So here there's a fracture. So they can design jigs to preemptively put the screws, and the plate will help you reduce. Even in shoulder arthroplasty, which is the bone is smaller, so jigs is quite helpful. Even for spine, when you put pedicle screws, you can pre-print a jig which guides you on where to put the pedicle screws. So what about the future? So this is a paper from China, which basically utilizes a 3D technology with augmented reality. So they segmented the vessels and also the nerve, the soft tissue, and they can minus off and turn where to put the cut. So yeah, they can augment the reality, so the surgeon can actually see the opposite femur, the pelvis, the nerves, and also the site where they are operating in. The problem is the surgeon needs to wear this high-tech surgical gadget. But yeah, I foresee it only getting smaller in the future. So yeah, it's quite interesting where the future will lead to us. But yeah, the ultimate aim is that when we do the cuts, this is how we do a knee replacement. So basically, we don't want to replace tissues with foreign material anymore. So we're hoping that we can print the biological tissue of patients and put it back into the patient. So yeah, that's what the future holds. So hopefully, even we can print the patient's tissue not only for surgery but for practice, because now we practice on saw bones, which probably gives quite a good feel. But yeah, obviously it's nothing like the real surgery. So when we can print patient's own tissue and practice on that will be good, give us quite a big advantage. So this is my second last slide. So 3D technology is new and exciting, but still in its infancy. So the indications are still quite narrow. Now we focus more on complicated cases. It does not guarantee good results. So even if you print, sometimes you still need to do a bit of troubleshooting. And you need to be there for the planning. You cannot just turn up and hope that the 3D guides just help you during the surgery. So you need to know what the plan is before you can execute it. So yeah, this is my last slide. So I think we can move on to the questions session.
Thank you so much, Dr. Khairul, for that interesting talk. And then you can see that how much the technology has evolved, and then assisting us in improving our surgical techniques and clinical outcomes of the patients. I mean, you've not really mentioned about the cost of this 3D printing. How does it actually, in terms of the costing, because we know that the implant itself can be quite expensive, and you have this additional 3D printing for your surgery. So how that actually, what's the cost really involved in this
Okay, so
cases?
for the cost, mainly it's for the raw materials. We use ABS, which is similar material to Lego, and it depends on how big the bone you want to print. Usually for the knee, the cost will be, it's quite expensive. It will be about 800 to 1,000 just to print the knee. But that also includes the cost of manpower, the planning. So yeah, it depends on the how much you want to print actually.
Safe to say that it may be costing an additional of about 1,000 per print, roundabout.
Yeah, for larger joints, the hip and the knee, it's slightly more expensive. For smaller joints, probably we can bring down the cost a bit.
Okay. Thank you so much. I think there's one last questions. Does printing take place in the OT?
No. The printing takes place in our 3D lab. We have a 3D printer by Stratasys, and we actually have to start printing at least about 5 days before, because we need to print, and once it's printed, we need to remove the supports. And after the printing has been done, in order to have it inside OT, we need to sterilize it. So this is one of the challenges that we face, because the jigs and the bone models are not heat resistant. So you cannot use your conventional heat sterilization, your autoclave. So we need to do gas, which is the sterile.
Okay. Last question quickly before we end the sessions. So how do you translate printing the real bone? And what do you use as bone?
Yeah, we obviously don't do this. This is basically from my reading. So when they print biological tissues, what they print is the extracellular scaffold, which is mainly the collagen. So for bone, it's collagen type 2 and a bit of calcium and phosphate. And to make this into live tissue, basically you have to engineer the cells and harvest the cells, and you have to fill up the scaffold with the live tissue. So this is also true for the other tissues in terms of heart. So the idea is that you have to print the collagen tissue, and after that you have to fill it up with the myocardium. You cannot print a cell. You only can print the structure.
Yeah. Okay, thank you so much, Dr. Khairul. Okay, we run out of time. So hopefully in the future, the bioprinting, we can actually print and organs, since it's very difficult to get the donors, especially in Malaysia. So we've been harvesting from the cadaveric bones, cadaveric donors. So hopefully in the future, it'll be a reality for our patients. Okay, I'm going to pass over the sessions to Associate Professor Chan Yok Fan for the second sessions under the Clinical Microbiology Department. Okay, thank you so much.
All right.